Hi, I'm Mark Weiss, and this is Fraud on Fridays. Here's a number for you, $556 million. Yes, that's what Kaiser Permanente's affiliates agreed to pay in January 2026 to resolve False Claims Act allegations that they submitted false diagnosis codes to inflate their Medicare Advantage reimbursements. That's a lot of money for a lot of diagnosis codes. And the alleged scheme didn't require fake patients, offshore call centers, or envelopes stuffed full of cash. It required diagnosis codes, real codes for real conditions, submitted for patients who couldn't be proven to actually have them. Medicare Advantage plans receive a per member per month payment from CMS. The payment is adjusted upwards based on how sick a plan's enrollees are, specifically based on the diagnoses those patients carry in any given year. The sicker the patient population on paper, the more CMS pays. That system is called risk adjustment. It's built on the theory that Medicare Advantage plans caring for sicker patients deserve more money to cover higher expected costs. That's not unreasonable. A plan enrolling mostly healthy 65-year-olds has a different cost structure than one enrolling patients with multiple chronic conditions. The systemic problem is the gap between patient actually has condition X and patient has condition X according to a code we submitted. It's in that gap that the ethically challenged see some clear blue sky. Most Medicare Advantage risk adjustment fraud cases follow a familiar pattern. A plan pressures a physician group to upcode, as someone eventually tells the government, and the case proceeds from there. But Kaiser is different. Kaiser Permanente is one of the largest integrated health systems in the country. It is simultaneously the insurance plan and the physician group. In many cases, the doctors who treat Kaiser patients are employed by Kaiser or its affiliated medical groups. The plan and the physicians answer to the same organizational hierarchy. That integration is usually presented as a feature, not as a bug. Align incentives properly, and everyone, plan, patient, physician, rows in the same direction. No fee-for-service treadmill, no adversarial prior authorization fights, one system, one goal. The DOJ's allegations suggest that at some point, one goal became getting paid more. When the plan and the physicians share the same roof, inflating risk scores doesn't necessarily require kickbacks or conspiracy meetings. It can require something far more subtle, a culture or a set of processes that encourages finding diagnoses rather than documenting them accurately. A chart review protocol that adds codes without supporting clinical encounters, a workflow that looks thorough from the outside and produces something different on the inside. The $556 million settlement was a civil resolution under the False Claims Act. No criminal charges, no physician licenses revoked. But $556 million is, well, still $556 million. And that's what a negotiated settlement looks like after the government decided it had enough to proceed. The underlying suit was brought as a qui tam action. A whistleblower filed the initial complaint under seal, and the government eventually intervened. Someone on the inside decided to tell the government what was happening. That person will receive a percentage of the recovery. That said, here are some timely takeaways for you. 1, the biggest, most sophisticated integrated health system in the country just paid $556 million for this. If the DOJ is willing to go after Kaiser, there's no impediment to going after your group. 2, know who controls your risk coding. If you participate in a Medicare Advantage contract and someone else, a plan, an MSO, a management company, is running chart review programs that generate additional diagnoses, you need to understand the methodology. Being paid directly or indirectly to find diagnoses in your patient's charts isn't always an innocent exercise. 3, integration doesn't mean insulation. If your group participates in an integrated delivery structure or a value-based contract with shared upside on risk scores, the alignment of incentives that makes it attractive can also create the conditions for a systemic compliance failure. That's worth scrutinizing before the government does it for you. 4. Somebody told the government. In the Kaiser case, as in many False Claims Act cases, a whistleblower filed the original complaint. Key TAM relators are usually current or former employees. Your billing coordinator, your coder, your compliance officer, anyone who sees what's happening in your revenue cycle is a potential relator. That's not a reason to be paranoid. It's a reason to have a compliance program that actually works. The diagnosis that wasn't there can cost you plenty. Stay tuned. There's always more fraud to unpack next Friday.